Dr. Khalid Sarwar to come and give us a talk about results of repair and reconstruction of the lateral ankle ligaments by newer suture anchors and synthetic ligaments in high-level athletes in northeast of Ireland, where Dr. Khalid Sarwar is working nowadays.
Thanks, Sajjad. It's looked like deja vu. I met Fahim after how many years? Long time. Sajjad and me trained as a very junior doctor, which some of you are, and that's a very pleasant reunion. And thanks, Fahim, for doing the talk and explaining all the literature that will help me to cut down my talk, and then we can just go to the main things there. So, as Fahim has mentioned, and we all know that this is one of the common injury we come across. I have no conflict of interest. That's a place I work in my private practice. That's a place I work in my trauma center there. That's in Drogheda. Sajjad might have worked and Fahim might have worked there as well. I acknowledge I got some help from Paul Maroney, Majid, and my senior registrar in preparing this talk. Some of this talk part is from the last year when they helped, and I've just added a few things there. So as Fahim has mentioned, that this is one of the common, and we have a lot of injuries, but in Ireland is different. This picture is from America, where the basketball is very common, but Ireland is different sports, which I explain you later, and then you can understand the region what I'm dealing with there. Normally, it's looked like deja vu. I met Fahim after how many years? Long time. Sajjad and me trained as a very junior doctor, which some of you are, and that's a very pleasant reunion. And thanks, Fahim, for doing the talk and explaining all the literature that will help me to cut down my talk, and then we can just go to the main things there. So, as Fahim has mentioned, and we all know that this is one of the common injury we come across. I have no conflict of interest. That's a place I work in my private practice. That's a place I work in my trauma center there. That's in Drogheda. Sajjad might have worked and Fahim might have worked there as well. I acknowledge I got some help from Paul Maroney, Majid, and my senior registrar in preparing this talk. Some of this talk part is from the last year when they helped, and I've just added a few things there. So as Fahim has mentioned, that this is one of the common, and we have a lot of injuries, but in Ireland is different. This picture is from America, where the basketball is very common, but Ireland is different sports, which I explain you later, and then you can understand the region what I'm dealing with there. Normally, ankle sprain is common in day-to-day life. We all can twist our ankle, have injuries, and then we go for treatment, and there where the rationale comes, which should we operate or not operate. But there are two types of people. One is a common people which can get sprained. One is a high-level athletes or a sports person which we need to address more aggressively. I won't go in the details of anatomy. Fahim already explained this, so we'll skip that. And we also be mindful of the deltoid ligament, which in my practice and my colleagues' practice, we rarely repair unless it is completely incompetent. Superficial sprain or most of the sprain do get settled unless MRI suggests you of complete rupture. Syndesmotic injury. This is important. I want to stress in this talk, don't ignore syndesmosis. When you have any ankle injury, sprain, or ligament injury, always check syndesmosis. It's very easy to check clinically. You have to palpate anteriorly or the syndesmosis area. If somebody is sore, you suspect there is a concomitant syndesmotic injury, and you need to evaluate with the help of MRI scan if the patient is still symptomatic. And you can, there's 10% of the ankle sprain have syndesmosis injury. And I'll show my cases that reflect in my practice as well. I do together lateral ligament and syndesmosis repair in those cases. So again, we all know these are the three different grades there, and in which we have different types of injuries involving ATFL or ATF-CFL or all ligaments, 3 ligaments, or deltoid involvement as well. Again, the same, what we've been mentioned before, you need to assess. You don't jump on treatment, surgical treatment, even high level athletes. 2 reasons for that. Number 1, it's when the tissue is very swollen and inflamed. It's not a good idea to go and attack it by surgical treatment. You make more complications. And second thing, as mentioned in literature, some of the injuries, most of injuries do settle, and you see what's the demand of the patient. That gives time for the patient to understand the injury, for you to evaluate patient more, and then you can decide the treatment, what is causing the trouble. Sometimes even the MRI scan is suggesting of some injury, but patient doesn't have those symptoms. Then you don't address that particular problem, because sometimes this MRI may be over-reporting. And I've been experiencing, I don't know, we can have a discussion, sometimes they over-report in some of the injuries, especially in the deltoid or some other ligament, they over-report these. So after this non-operative treatment, the patient which comes after 3 or 6 months and is still not able to go back to sports and problems and rehabilitation is not successful, then you can think about what are the features, how we can treat it. Your assessment is important, clinical examination is important, and then you have more correlation with clinical examination and MRI finding. This is also a squeeze test in syndesmotic injury, which I mentioned. That's one of the signs you have to check, and also palpate anteriorly on the syndesmosis area. If it's tender, you also suspect syndesmotic injury, need to address that. You assess completely, and then you take images to help your injuries to assess it. Arthroscopy is sometimes helpful before you jump into final conclusion, but normally it is done in very small percentage of cases. It is an option, but it's not done in most of the cases there. If you are suspicious of any osteochondral defect, then you do an arthroscopy. If MRI scan is suggesting and X-ray suggesting, then you need to check how bad is the defect. Most of the defects are contained and the superficial cartilage is intact, and then they will settle it. And you need to address on ligament instability so that avoid any continuous insult on that. Stress X-ray has been out of fashion now. And when we exhaust the non-operative treatment, we mentioned already, Fahim has shown the braces. You try all these. And I'll try to skip because I need to focus more on the different type of treatment. This has all been mentioned, so we move on to that. So this is typical anatomic repair with the Bostrom and Gold. And this now comes the internal brace. If you look at this, what Fahim has mentioned and what's been mentioned in literature, what is internal brace? Internal brace is a synthetic ligament which is made with a fiber tape. The problem with this synthetic ligament is they are not stretchable, they are very stiff. But sometimes you need to support the repair, especially in high-level athletes. So you have to be using this technique cautiously. It's not for every patient, but you have to use in selective patients. And in those cases, like this is one of the cases I just put it that you are assessing, and then you assessment, is the pointer working on that? So again, the incision, then you try to assess, you develop the plane and raise that ligaments, ATFL, CFL here, and the retinaculum together. You place your suture anchors. There are different types of anchors. Again, I don't have any affiliation with any organization, but Arthrex has got very good instrumentation, not promoting. You have other instruments which can hold the anchor, and the fiber tape or fiber wires are good. So you need to mark and place your sutures in advance that where you will be doing. If you look at this, I made marks already to put the anchors where my anchor will be going. And after this, And before even you do, it's a little mix up of the slide, you need to mark and assess where your structures you are trying to find. And once you have done this, this is the augmentation brace. If you look at these, this is the Brostrom Gold repair, and this is the drill for the internal brace. So the important is I don't use any radiology or image intensifier in my normal lateral ligament complex repair, but when I'm using internal brace, I put it standby in cases. If I'm using this, I use image, because it's if you see this one, 3.4 millimeter drill and 4.75 soil lock. That's a big size, and its length is also about 25 millimeter. So you need to be sure you're not crossing and going into ankle or going down in the subtalar joint or towards the lateral side. So you need to be sure that your drill is going in the right direction. Then you put the soil lock in one side, and if you look at this one, that's one side anchored with the internal brace there. And then you just repair it, and you keep it on the side to go on top of it as a reinforcement. Once you have repaired this, you are using another soil lock which is smaller because it's going on the fibular side. You cannot use 4.75 on the fibula with a 30 millimeter. So this is a smaller intermediate one, and you tighten this, and that's your internal brace on top of your ligament reconstruction. That gives extra stability. But very important thing to note, don't over tighten. For the Brostrom Gold repair, you try to over tighten and make it as strong as possible, but because internal brace is very stiff structure, you don't want to over tighten and patient come with inverted foot and ankle and cannot walk properly. So you need to go in the physiological limit there. And I'm just giving you example what we are dealing in Europe, in Ireland especially. As I mentioned, don't forget about syndesmosis injury in these ankle ligaments. There's no harm. When you're getting MRI, do ask question. Please comment on syndesmosis as well. Because if they comment, you can deal straight away with the same incision. And by the way, I don't mind about extending incision. All these players, they don't mind about big scar. They want to go back to sports. That's what they want. So just give you an idea about Irish sports. We have GAA, Gaelic Athletic Association. There are 4 sports in there, which is very common, like cricket in Pakistan. So you have Gaelic football. They commonly call football as a Gaelic football. It's a different type of football. They can hold the ball in the hand and keep tapping on the floor, on the ground, and then they kick it as well. This is different. The normal football, what we call football, is soccer. Then there's a hurling in the female, it's called camogie. That's also a very, very competitive and contact sports, and a lot of injuries occurs in these sports. Then there are different types of rounders and handball. They are not very commonly done there. So this is one of the case which I had syndesmosis injured and extended. And if you see, I don't mind extending and then putting the two after debriding the syndesmotic area. It's not like only putting tight, because by the time they're coming you, it's 3 months, 6 months. You need to debride that syndesmotic area properly. Exposure is important. Then you repair with a tight rope. Even you can put a screw, no problem, but you need to stabilize the syndesmosis so that you can, because of athlete, we don't want 2 surgeries, we just use a tight rope there. So internal brace is mainly is a wide failure and this torque failure. So you have to be selective what type of patients, not for every patient. For somebody who's very demanding, who want to go back to sports early, and you are worried about the results, then you put it on. And I think this is the one which papers have showed, which Fahim has mentioned as well. And arthroscopic versus open repair, yeah, I don't do arthroscopic. In my hand, I feel more confident. I do open and have good results, and I don't have experience for arthroscopic, but just literature says it's the same results there. Non-anatomy we've already spoken. And if you talk about, there's a medial side, I just mentioned that if you come across medial side, you can also use the same type of structure, internal brace, or these ligaments reconstruction on the medial side. Now, this is the literature which we already mentioned and know. They are good results, and augmentation is also quick rehabilitation and avoid future injuries and failures. I just give you a few examples of my cases quickly to give you an idea. So like this is a male who got left ankle ATFL, CAFL using internal brace. And the MRI is important, in which you need to know there's an avulsion fracture on the lateral side, which also suggests the injury was very significant. And you need to have these all information before you decide about these. And this is the angle of the, if you look at this, this is the final soil lock I'm pushing in there and checking under image that where this soil lock will go. I don't want to go in the joint. I don't want to go, this is the one in the talus there. So that's where I use the images. And you check the syndesmosis as well, that is it opening or not opening. Now this is another example in which we have this arthroscopy was done just to check osteochondral defect was mentioned. And that's where we want to be sure. He's a young man. If you look at, he's only 15 years here. By the time I did, he was 16. So we want to, is nephew of one of my staff members. You have to be sure everything is fine. So we did arthroscopy, and we found the osteochondral defect, which you will see in there. Look at this one. That was contained. That was cartilage over, it was smooth. So we didn't do anything. We just repaired the ligament. And he's very happy. He's a very active athlete and very happy. I didn't hear back. So again, the same complete tear. You get some support with the scans and things, and then you will assess. In this case, I suspected of syndesmosis. Clinically, the patient had syndesmotic pain complaint, so I augmented with my syndesmosis repair there as well. And results were good. The same, you always check these different type of anchors, and then you just do the internal brace I use in this case as well, is a high-level athlete. So in summary, you have to be selective where you have to use. Don't forget the different injuries in the same patient or in that region. And syndesmosis is one of the very important one you need to assess. And always try conservative treatment. And if it's not working, then definitely Bostrom Gold is a gold standard. But in high demand and high risk patient, you can do internal brace. And rehab is the key to the success. Thank you.